Hey guys, welcome back to St3 Hacks. And today's episode is going to be a bit of a long one, but it's one of the most high yield pediatric trauma topics at the St3 level, where interviewers are testing our judgment around neurovascular compromise, escalation, and when not to delay. So, the background knowledge and what you need to know before you walk into the station. Supracondylar fractures peak between the ages of 5 and 8 years of age. And this is the sweet spot where ligamentous laxity is really high. Kids can fall onto an outstretched hand and the elbow is hyperextended. The olecranon is relatively strong, but the distal humeral metaphysis is not. So the olecranon drives into that weaker bone, producing this classical extension type injury, which accounts for the vast majority of the cases. It can be flexion type, and we'll talk about what those mean in a bit. The Gartland classification here matters. So there's 4 types. And Gartland 1 is an undisplaced fracture where it's conservatively managed mostly. A type 2 has angulation with an intact posterior cortex of the supracondylar region in the humerus distally, and they often need fixation if the anterior humeral line does not intersect the capitellum. Type 3 is a fully displaced fracture and needs operative fixation. And in some books, there is a mention of a type 4, which is multi-directional instability in both flexion and extension, and that needs an operative fix as well. Moving on to the radiographic features that you need to comment on. So on the X-ray AP view, you should say that I'd assess the Bowman's angle, which should be around 72 degrees. A difference of more than 5 to 10 degrees compared to the other side suggests a coronal plane malalignment and can risk a complication called cubitus varus, which may really impact the future mobility of that child's arm. On the lateral view, you need to comment on assessment of the anterior humeral line, which should intersect the middle third of the capitellum. A slightly advanced nuance is that in younger kids, especially under the age of 4, the anterior humeral line may just intersect the anterior third or may just touch the capitellum. But as far as the interview is concerned, you should say that the anterior humeral line should intersect the middle third of the capitellum. Another thing that is a subtle sign is the presence of the fat pad sign. The posterior fat pad is always abnormal and suggests an occult fracture. And you can search this on Google Images. It shows that it's the bone has bled and it's in that space within the joint fat pad. There is also the radiocapitellar line, which should be passing through the midline of the radius and should be intersecting the capitellum on all views. And I think is enough to sound fluent and safe. Moving on, let's talk about the nerve injuries that can happen in a supracondylar fracture. There are 2 types of supracondylar fractures, and they are defined by the position of the distal fragment in relation to the extensor and flexor compartments of the forearm. So an extension type injury is where the distal fragment is pointing down towards the extensor compartment, i.e. the dorsal surface, and a flexion type injury, which is caused by the fragment moving up towards the flexor compartment of the forearm. The injury, however, is not dictated by the distal fragment. It's indicated by the proximal, bigger humeral fragment. So in an extension type injury, because the distal fragment goes towards the extensor compartment, the shaft of the humerus moves forward, and that impinges on the median nerve, and more specifically, the AIN, the anterior interosseous nerve, because the most posterior fibers of the median nerve are the AIN fibers. In a flexion type injury, the shaft of the humerus is pushed back as the distal fragment moves up, and that can damage the ulnar nerve. Okay, I didn't understand this concept because it's described by the distal fragment, but the nerve injury is dictated by the proximal fragment. So please listen to it carefully, as it is quite confusing. And it's key because this is high-level stuff that really differentiates candidates. Now, the key concerns here are 4 things. If it's an open supracondylar fracture, if it's an impending open supracondylar fracture, if there is an absent radial pulse, and do they have a clinically impaired digit perfusion. So these are the 4 indications for overnight surgery. Open, impending open, absent radial pulse, and clinically impaired digital perfusion. Let's move on to how you would describe a radiograph of a supracondylar injury when it's presented to you in an interview. You need to ask for an AP and lateral. You need to say which site it is, if it's right or left, and figure that out with the forearm bones. You want to comment that it's a skeletally immature patient. You want to highlight the salient abnormality being a supracondylar fracture, i.e. a flexion and then extension. And then you can comment on the Gartland type. You can then also mention the anterior humeral line, which may not intersect the middle third of the capitellum. And remember, in kids under 4, the line passes through the anterior third. Key concerns here for you are open injury or impending open injury, neurovascular compromise, especially perfusion to the digits and radial pulse. And key thing that would be a red flag if you missed it, exclude signs of NAI in the history and the examination. There are key guidelines that you should be aware of in this case. Firstly, the best practice guidelines for supracondylar fractures. Secondly, if there's subsequent peripheral nerve injury, there is also a BOST guideline to manage those. Now, moving on to our triple assessment. You want to say something like, I would approach this patient with an ATLS approach, ensuring they have a patent airway with appropriate C-spine control, assuming this is an isolated injury. I would then move on to complete a full skeletal survey and continue managing any presenting injuries. In the history, you can say, I'd introduce myself to the child and guardians and inquire about the time and mechanism of injury. I'd take a Socrates pain history, a relevant ample history, a social and pediatric history, specifically mentioning hand dominance, previous injuries, and pertinent medical disease. In the examination, I would use a look, feel, move method with a thorough neurovascular examination, assessing the warmth and color of the hand, capillary refill time, radial and brachial pulses, and excluding an expanding hematoma. I'd use a Doppler as necessary to test the vascularity, and I'd test the sensory autonomous zones of the radial, medial, and ulnar nerve. And you need to really know those. So they would be the first dorsal web space, the pulp of the first finger for the median nerve, and the pulp of the fifth finger for the ulnar nerve. I would then test the motor function by asking them to show me a rock, paper, and scissors, i.e. a median, radial, and ulnar nerve examination, and then specifically the AIN sign, which is an OK sign, especially concerning in a flexion type injury. Investigations, I would ask for a trauma bloods, x-rays, AP and lateral, and consider a Doppler and a CT angio if I'm concerned about vascular injuries. From hereafter, the station can go down 3 routes. If the limb is cool and pulseless, if the limb is pink and pulseless, and if the limb is pink and has a pulse. Okay? So, if the limb is cool and pulseless, normally it requires urgent reduction, normally in theatre, and fixation restores circulation in about 75% of cases. As most often, the brachial artery is spasmed or trapped within the fracture rather than having a true intimal tear. So that's knowledge that you should know if they push you on it. If there are ongoing concerns regarding perfusion post-reduction and it needs further surgical exploration, you should ask for an urgent vascular opinion, which may warrant surgical exploration. And this is where situational awareness is really important. So if you're in a DGH and you don't have vascular, you need to expedite that earlier and be like, I need to speak to the vascular registrar at the different site, ask them either to come over or send the kid urgently, whatever's quicker. Vascular studies, however, such as a CT angio, should not delay urgent surgery or reduction of these injuries. If the hand is pink and pulseless, BOST outlines that an absent radial pulse should be taken to theatre overnight. However, the nuance of this is that this is a consultant-led decision, and I would inform them and prepare accordingly. Some literature indicates that if assessment for nerve injury is positive, then there's likely to be coexisting vascular tethering at the site, and this would require emergent reduction. And if the pulse does not return, an exploration could be warranted. Okay, so if the hand is pink and pulseless without nerve injury, I would closely monitor the patient for 48 hours. Moving on, management. So you would start initial management with appropriate analgesia and pediatric A&E. I'd immobilize the arm in an above elbow back slab in 20 to 40 degrees of flexion and assess and redocument neurovascular status. For definitive management, I'd make the patient kneel by mouth, gain consent from the guardian using a consent form 2, consent in simple non-jargon terms for MUA, manipulation under anesthesia, plus or minus KY fixation, open, plus or minus closed, and ensure I answer any concerns. What happened before? There is a plaster, then the ward, then the operation, roughly half an hour, then stay on the peds ward until we're happy that everything is safe, and then follow you up in clinic. This is if the case goes into, this can come up in a management station as well, and how you communicate. The aim is to achieve anatomical reduction, avoid cubitus varus, avoid iatrogenic injury to any nerves or vessels, and relieve the pressure on neurovascular structures. Risks. So there are general risks to this. So pain, infection, bleeding, neurovascular damage, stiffness, malunion, non-union, and anesthetic risks. And then specific procedural risks for supracondylar operations, which are pin site infections, pin migration, gun stop deformity, Volkmann's ischemic contracture, and altered limb length or growth deformities. How would you reduce this case? So, reduction is performed using the principles of traction and countertraction. That's kind of the basics of orthopedics, right? You want to disengage the distal fragment from the pull of the brachialis muscle. You want to correct medial and lateral translation in the coronal plane first. And then you would flex the elbow with one hand, palpating the radial pulse, whilst anteriorly pushing the olecranon to correct the deformity in the sagittal plane. Then you would hyperflex the elbow to 100%, pronate the arm as it tightens the medial periosteal sleeve. I'd then check the position with the image intensifier and ensure the correction of the Bowman's angle with no varus or valgus deformity. Importantly, something I learned after the interview was actually doing this case as a CT2 is that you need prolonged traction up to 5 to 10 minutes, depending on the size of the child. Okay. So adding that to your spiel would really differentiate you. But this reduction spiel is key, and I would really learn it inside out. Moving on, if you're doing well and you have time, they may ask you, how would you perform the operation? So you would start with the operative spiel of, an appropriately marked, consented, who checklisted patient. I would have the patient supine with II present in the theatre room and perform prolonged traction. I would then consider a lateral divergent or crossing KY approach. Okay. In this scenario, you would use 2 millimeter KYs as per Bose guidelines, 1.8 millimeters if they're less than 4 years old, and ensure there is bicortical engagement across more than a third of the fracture length to prevent any rotational instability. The crossing KY approach increases risk of iatrogenic damage to the ulnar nerve, and this can be reduced by doing an open approach with the elbow in extension from the medial side to identify and retract the nerve carefully. You want to also mention that you want to aim for 2 wires across 2 different planes so that they're resistant to torsional forces. The aim is to avoid cubitus varus by achieving Bowman's angle similar to the contralateral arm, and you want to ensure that this patient is followed up in fracture clinic in 1 week and then KYs out in 4 weeks. Okay, so there is a lot of content there, and I think you may need to re-listen to this episode and read around it, make yourselves familiar with the Bose guidelines, and really dive into this case radiographically and pathology-wise. I wish you good luck. If there's any questions, please reach out to me on any of the platforms and comment on this podcast, and I'll see you in the next one. Take care.